Welcome to the Doc Talk, everyone. So, this is episode 2, and today we're going to be talking about a very relevant topic, testosterone replacement therapy.
Yeah, that's it's actually really exploding right now.
Mm-hmm.
I easily get per month maybe 5 or 6 patients coming into my office asking to be checked for testosterone or coming with symptoms of low testosterone, basically.
Yeah. Okay. So, this is something you've been, incorporating more into your practice and learning about. So, what prompted you to do this? Because it's not, I wouldn't say it's not something that we normally do. I would say it's something that's not as prevalent to be checked in a family medicine office, you know, because most people are normal. So,
Correct,
what
correct.
prompted you to start checking it?
So really, what really got me into this was I had a patient in my practice. I was doing a depression and anxiety follow-up, and when patients come to us, we reconcile their medication. So I'm
Yeah.
just like cleaning up his medication list, and he says, "Oh yeah, I'm on testosterone." I'm like, "What do you mean you're on testosterone?"
Mm-hmm.
He's like, I went to this wellness clinic in town and they did some blood work and then they decided that, he's a good candidate for testosterone replacement therapy. And then they initiated him on that. Um, at that point in my career, I was very naive to this whole testosterone replacement therapy. I mean, we know the basics that if you have a medical condition,
Mm-hmm.
like true low testosterone levels, whether it's due to the testicular cause or something in the brain,
Mm-hmm.
uh, we know what to do with that. You send them to
Yeah.
endocrinology and they take care of all that, replacement stuff and investigate further why. But hearing from this guy that he's on replacement therapy for not having low levels per our lab standards
Mm-hmm.
was something, I was like, wow, what's going on here?
Yeah.
So then I called up the clinic. I spoke to them, we had a discussion and it intrigued me. And then I did a subsequent follow up with this guy, and he stated to me that he stopped taking his depression and anxiety medication a few months ago. I was like, oh, what happened, man? He's like, I started feeling much better, and those guys told me that, with replacement with testosterone replacement therapy, you may not need your depression and anxiety medication anymore.
Mm-hmm.
So that got me even more curious, and
Mm-hmm.
that's how I went down this rabbit hole of what this whole testosterone replacement therapy is outside of clinical deficiency.
Okay. So tell me more about that. You say clinical deficiency. So what you're saying is typically at a doctor's office, if you have low testosterone, so below the lower limit set by the lab, then you would replace testosterone replacement therapy. But if your level is above that lower limit, then it's considered normal and it's not typically something that's replaced.
Correct.
But testosterone replacement therapy for optimization is a little bit different.
That's
Okay,
absolutely
so tell me
correct.
about how that's different.
So the typical current total testosterone right now that we go off of is about 300 to 1,000. That's the standard. Some areas differ a little bit up and down, plus or minus, but that's the standard 300 to 1,000,
Mm-hmm.
which, if you look back, has been coming down every decade. But that's a topic of discussion for a different time of why,
Right.
what's going on
Yeah.
with that. But right now, 300 to 1,000.
Right.
So as you may imagine, that's a huge range.
Mm-hmm.
So you may have an individual sitting at 300 who is feeling awful, uh, who may actually feel better if we were able to take him up to, let's say, mid-range, 500, 600,
Right.
middle to upper normal.
Right.
He may feel much better.
Mm-hmm.
At the same time, you may have a guy who's sitting at 300, absolutely no symptoms.
Mm-hmm. So what are these symptoms? What typical symptoms would a man see, at 45, 50, when typically the testosterone levels start to fall?
Good question. So it could be a whole host of symptoms. I mean, the list is huge,
Mm-hmm.
but some main ones, that come to mind that everybody brings up to us: fatigue, low sex drive, brain fog. I just don't seem to have that drive that I used to have,
Mm-hmm.
even a few years ago, not like 10 years ago,
Yeah.
even a few years ago. Um, I'm doing everything right. I exercise like 5 to 6 times a week.
Mm-hmm.
I try to eat clean, whole foods. I
Mm-hmm.
stay away from processed junk, sugar, all that. And yet, for some reason, I hit a wall.
Mm-hmm. So it sounds like the patient that's coming to you with these symptoms is already doing things to make their lifestyle better. Like they've already worked on the sleep portion.
Correct.
They've already worked on their diet. They're already incorporating exercise into their lifestyle. So they've done the basic things that you would tell somebody to improve on before you went on this journey.
That's correct.
Okay. So talk me through a process now. So say a patient comes to you and, again, you have this 45-year-old man, he's coming in, he's just feeling tired. He feels like he's a little bit more anxious. He feels like he's not typically well rested. His libido isn't as high as it used to be a year ago. So you figure out, you decide that you need to check his testosterone. You check his testosterone level and it comes back at 350.
Okay.
Okay. What's the next step?
Good question. So 350, the next step immediately is to recheck this,
Mm-hmm.
because you never go off just one lab test.
Right.
You must be able to reproduce this to make sure it's actually accurate, which is the case in a lot of things we do in medicine. We don't
Mm-hmm.
just jump off of one thing and
Right.
start
Yep.
repeat it. If it comes back again low at that age, what did you say it was 45?
Yeah.
So 45-year-old male, 350, naturally the production in his testicles is already declining.
Right.
So is this a natural decline now? But still, you have to investigate further. You cannot just think it is and call it a day. So we need to get further lab work. Remember, I was saying that there are some clinical
Mm-hmm.
diseases. So we
So to
get
figure out what's causing the testosterone to be
exactly.
low.
We have to
Okay.
investigate further. You
Yep.
cannot just assume. So we try to rule out the clinical causes, the primary, secondary issues that's causing this.
Mm-hmm.
We look at medication lists, drug abuse, XYZ.
Yep.
You got to do a great history. You
Mm-hmm.
must take a thorough history, investigate further.
Yep.
If after all the investigation is complete and honestly we are unable to really pinpoint something that's causing this, we've
Mm-hmm.
already ruled the bad stuff out. Okay, so the bad stuff is out, but everything else seems to be in check.
But he's
Then,
still
but
low
he's still
normal.
feeling these
Yeah.
symptoms. Then this is the prime candidate
Mm-hmm.
that we start having a discussion about testosterone replacement therapy optimization
Right.
to see if we boost his levels from the low 300s up to, like, let's say 600, 700, and see if we notice a difference.
Right. So now say you start him on testosterone replacement therapy, and it could go one of two ways. So he comes back to you for his 3-month follow-up and he says, oh my God, wow, my life is different. I
Mhm.
feel so much better. Or in the second case, he comes back to you and he says, well, nothing's really changed. So do you then still continue this for longer? Do you aim for a higher point? Or do you say that, what, then maybe this wasn't the reason for your symptoms?
That's a very case by case basis
Mm-hmm.
question, honestly. If truly so if you've done it for, like, let's say 3 months and there's absolutely zero difference,
Yeah.
depending on the patient, their motivation, their desire, I have a discussion with them. We can just cut it right there and be
Mm-hmm.
like, you know what, it's fine. We don't need to proceed any further. We can explore other etiologies, causes, and see what's going on. Then there are some patients that we could wait a little longer, but here's the caveat to this. This is why it's a very personalized
Mm-hmm.
care. This is not like a cookie cutter, one size fits all.
Right.
The longer you keep somebody on testosterone replacement therapy, the higher the chances of their natural production not kicking back in.
Right.
Right? So that's the number one thing with testosterone replacement therapy. If you're going to sign up for this thing, this usually is a lifelong commitment. This is not something you get on for a few months, maybe a year, come off. That is
Mm-hmm.
not how it works.
Because it's a hormone that we're putting into your body from the outside.
That's correct.
So it overrides your body's own
Natural
feedback
production.
mechanism
That's
of
correct.
the
That's
testosterone.
correct.
So say you were to take it for 10 years and then suddenly go off of it, your body is now not going to be able to produce as much testosterone as it would have been
That is
producing had
correct.
you not been on
And
it.
that is one of the discussions that we have with the patients. You have
Yep.
to have full informed consent. The patient needs to understand everything
Yep.
before you give them testosterone replacement therapy. Complete consent
Because it's
and
not a benign
information. Oh,
medication, right?
definitely
Yep.
not. Now, do we have things that we may be able to kickstart you down the line? Yes, there are. Mixed reviews, take it as you may.
Yeah.
But for the most part, yeah, it shuts off your natural production.
Mm-hmm.
So if you're going to consider this journey, you really have to understand that. Then there are some myths out there about you developing prostate cancer. That's false information. Um, Testosterone replacement therapy does not cause prostate cancer. If you are prone to it and you're going to get it, it may expedite that and you may show symptoms sooner. Um, but no, it's not going to cause prostate cancer.
So what are some of the real risks?
The real stuff, you need to be watching, your blood counts. You got to make sure your blood doesn't get too thick because then you can run into a risk of having blood clots and strokes and that kind of stuff. You need to be, of course, watching the PSAs, the prostate numbers, and you got to make sure that those stay steady. Nothing crazy is going up
Mm-hmm.
so high or even fast. You watch the cholesterol numbers and liver markers. Although with the injection stuff, not so much because we're not doing oral replacement. The oral stuff, affects the liver more.
Mm-hmm.
So with the injections, it's different. But still,
Yeah. And estrogen levels another
estrogen
one,
levels,
right?
100% you
Yep.
have to monitor estrogen levels because testosterone can raise estrogen levels too. So typically we get baselines, then I like to clinically watch them. If they're displaying symptoms of high estrogen like emotional issues, they're
More
just feeling more
labile.
labile,
Yeah.
mood instability,
Mm-hmm.
that's going to clue me in on, okay, maybe the estrogen level is a little too high. Let's see what's going on. And
Yeah.
then we mitigate that by dose adjustments or frequency. There's a whole
Yeah.
different algorithm.
So this sounds like something that once started requires very close follow up. So
Correct.
it's not like I found this website online and there's somebody there who's going to send me some and then they'll check labs a year later.
Absolutely not. That is the biggest issue right now that we're facing is these online companies. They just sign up a bunch of people, they fill out some surveys, you meet some random provider, and boom, they're on testosterone replacement therapy. No, this is a very patient by patient thing, and it requires a lot of care, a lot of history gathering, physical, routine monitoring.
Mm-hmm.
Absolutely not. You cannot be on testosterone replacement therapy and not at minimum have your labs checked twice a year. That's minimum.
Yeah. So that's
So
one of your ways of knowing if the provider that you're dealing with
it's
is
legit.
safely treating you. Yeah. Yeah.
Correct,
Is that they
correct.
should be seeing you pretty frequently.
Correct.
Yeah.
Because there's mitigation strategies, right? If the blood becomes too thick, you don't necessarily have to stop the testosterone. A really good strategy is go to do some blood donations, You help yourself and you're helping
Mm-hmm.
the community with some blood donations.
Yeah. Yeah.
So that's why you have to be monitored routinely. That would be my take on testosterone replacement therapy as a family physician.
All right. Well, guys, we hope you enjoyed that. We'll be back with another episode pretty soon.